Dr. Merrill.
So welcome to January 3rd, 2018, our first Journal Club of the year. I understand I was away 2 weeks ago, and I understand we had 7,000 viewers, so maybe I should go away more often. And I guess next week we will be in San Diego, right, for NAMSP. So we won't do Journal Club next week unless we want to fly all this equipment to San Diego, which I guess we probably won't do. But maybe we'll do something at some point. But if nothing else, 2 weeks from today, we'll be doing Journal Club again. We just came back from Staten Island University Hospital to give a lecture to their emergency medicine department, emergency medicine residents about the fellowship, and we did an EMS literature review for them. And then we have a few other hospitals in New York that we're going to sometime in the next month or two. If you want, remember, always go to our website, www.emsfellowship.com, and you can pretty much find anything you need to know about us on our website. And you can always ask to join our email list, which is up to like 11,000 people now from the articles. In the last week, there actually been like a lot of great medical articles that have come out. So I probably the next couple of days will send 20 articles out to read over the next 2 weeks for everybody. So lots of really interesting stuff for everybody to know. So we will start with interesting cases. Any interesting pre-hospital cases or emergency department cases in the last 2 weeks? Who was on primary?
I had an interesting case in the hospital I worked
And we're trying out our new microphones, right?
Yeah.
So hopefully you should hear us much better now.
I push it. It's on, I think.
It's
working?
on? Okay, great.
It says on. So, yeah, I was working in the ER at one of the hospitals that we work at, and some guy walks in and says, I think there's an emergency outside. There's a car that backed into the wall and is smoking. So we're like, uh-oh. So we walk outside, or actually all ran outside, and we see that there's this car that's in the ambulance bay backed against a brick wall. And there's like all these sparks and smoke coming out from underneath the car. We weren't really sure if the car was going to explode or not, and we didn't really know if we should be running over kind of at that time to the car. It was like a little bit of a dangerous situation. So I started to kind of go over the car, and then we heard this loud pop, and at that point we're like, maybe it's time to take a step back.
What was the pop?
I think it was a tire that actually popped. So we figured this out afterwards. What happened was that I still don't know what caused the guy to go into crash, but I think it was probably due to respiratory distress and probably respiratory arrest. But I assumed that he was probably driving to the hospital and then got into the ambulance bay, and then something happened. The car was in reverse. He went back in, and then I think all the sparks and the smoke was coming from the wheels that were just rotating against the pavement. So I think what happened was we heard that pop, and then shortly after, all the sparks stopped. So I think the car may have run out of gas. So I think the sparks and everything were coming from the rims on the concrete, because the concrete was burned after the car was moved. So once the sparks stopped, we all, even though it was still smoking, we ran over to try and get the guy out of the car. He was unconscious in the driver's seat, but all the doors were locked. So now we had to break the car window, and it's really not that easy to break a car window. We've never tried it before. So, when the security guard was there, he was like trying to hit the car with the butt of his gun, which wasn't working, and someone got a fire extinguisher and tried to do that.
So EMS, what about the window punch? Yeah.
Well, so the EMS, I don't think there were any, I don't know if there were any EMS vehicles in
They hadn't arrived yet.
Oh, no, well, EMS, it was just a guy in his personal vehicle, basically, yeah. So there weren't any EMS vehicles with a window punch, but I definitely think it's something important to have, especially if you ever need to try and break a car window. And it really just showed me firsthand, it's not that easy to break this car window. But eventually we end up, I think someone else in the hospital on the back of one of their trauma shears had a little window punch and whatever, and basically was able to make a small hole, and then we end up getting through the passenger seat. We dragged the guy out of the car and brought him into the resuscitation bay where we intubated him. I mean, he was wheezing. He was a big guy. He had bilateral subconjunctival hemorrhages, and I think that what probably happened was he was maybe an asthmatic and ended up going to respiratory failure prior to getting to the ER and actually making it in. I guess he's lucky that it happened right in front of the ER and not somewhere else because he could have died. I mean, after we intubated him, which is not such an easy intubation. He was a big guy with a huge tongue, but we ended up intubating him, and I don't know. I got to follow up to see how his mental status is now, but I just thought I brought up a couple of interesting points of like getting access to these vehicles, and having a window punch is definitely something that's important. Especially because if you're, let's say, the only EMS unit out in the field and you don't have anything, what are you going to break open a window with if need be? I mean, maybe fire department will be there and can help you out with that. And then we had a discussion as to if this guy should be pan scanned or not. We weren't in a trauma center at the time. The mechanism was kind of a low speed, presumably low speed. He was backing up in an ambulance parking lot, but then again, he was unconscious. So yeah, I don't know. Would you guys pan scan this guy?
I don't know. I think about the woman who was in an MVC pulling out of a bank, one of those bank ATM windows, and she was just pulling out, became unconscious. She must have been going 5 miles an hour, and she had she actually transected her spinal cord from a very low level, 5 miles an hour, and she came in paralyzed. And when she woke up, we figured that out. So I think about those cases that make no sense. I mean, you didn't see it happen. It probably was low level. I guess the question is, what's the downside?
Right. Yeah, we ended up hand scanning him. I mean, that was the decision we ended up making. Although, I mean, it was kind of like, well, should we do it? I mean, I guess the downside is just the amount of time, and the guy was going to get a head CT anyway. So I guess if he's already on the table, then does it really matter? I mean, it's just the time that someone's in CAT scan. And I mean, people do die in CAT scan all the time.
Right. But a neck obviously adds another minute or two.
Right. The head and neck are quick studies, but then once you start doing the whole body stuff, and then spines, and delayed phases, you could be in there for 30 to 40 minutes sometimes.
I mean, how often have you scanned the head for like an MVC where you didn't do the neck? Right. Like I certainly, if somebody hits their head, I'll scan their head sometimes without their neck. But can you remember a time when you scanned a head only without a neck for an MVC?
I mean, if they were awake, there's no loss of consciousness. They passed all the other rules.
So they're 80 years old. They meet criteria for a head CT.
Just do the neck. If they're 80.
Right. I mean, I just can't think of a time where I took somebody who's a driver in an MVC, who I was scanning their head and I wasn't doing their neck, especially somebody who's older.
But usually,
we have little old ladies who fall off toilet bowls who have type 2 odontoid fractures, and that happens, every now and then.
Yeah,
And
usually if you
think-
have a reason to scan the head, it's a reason to scan the
If you
neck.
think of the mechanics of getting in a car accident too, I mean, when you're going forward, you're gonna hit your head. Here you get a coup counter coup. That's what you think of, but you can also get the extension injuries. So any extension injury of the spine is, if you hit your head hard enough to warrant a CT of the head, you got to consider the extension injuries.
Like
too.
essential cord syndrome?
Yeah.
The most common spinal cord syndrome, and for some reason the paramedic books don't talk about it all that much, right? It's what we talk about all the time, central cord syndrome. And at the pre-hospital, I don't think they just describe. It's not in the paramedic books, is it? It's in PH central cord syndrome. All right, keep going.
Yeah, so I was just, I think it's just a couple of lessons I learned from that. The window punch, I think, is definitely something that's important to get someone out of a car. And I guess it's always a tough decision. I mean, a guy who's over there who's like unconscious and in a car that's smoking, you run over to the car and try and get the guy out, and how many people are you willing to risk for, or who's willing to risk themselves? Are you willing to risk yourself? It's tough decisions that I guess got to be made in the moment. I mean, luckily the car stopped smoking and then it was easy. It was only a couple of minutes.
Yeah.
I mean, we talk about scene safety and all that stuff all the time, but at the end of the day, when you see some guy in a car, it's not so easy to kind of just stay back.
Everything is scene safety by substance isolation, right? Scene safety
Yeah.
by substance. But I remember the statistic, which was probably completely made up, that somebody taught me years ago, that said only 1 in 50,000 cars catch fire after EMS arrives on the scene. It was in some book. Who knows if it's true? Some
After
author probably
EMS,
made it up.
well, there's usually a delay in EMS response. There's usually
Right.
So I was there. We were there in like 30 seconds. So I don't know. Yeah.
But who carries like a window punch? Did any of your ambulances ever carry them?
I never.
Yes.
I don't think the ambulance
You carried
did,
a window
but
punch.
I have one with me at all times.
Yeah,
Really?
It's on
I
my
carry
deck.
one on
What
my
about fire engines? Every fire engine have a window punch? Every
rescue
fire
trucks
Yeah.
do. Yes.
Every rescue
Every
truck.
fire engine has one, at least in New York.
Interesting.
So what I recently bought was a car charger that actually has a window punch on the bottom. It's like a USB charger, so it actually has a window punch on the bottom, and it has a seatbelt cutter on its side. So it's right there where I charge my phone in. So if ever I get, I need to extricate myself, I can pop that off, cut my seatbelt, and then punch out the window and get out. So, these are things that you always got to think about,
You're a big guy, though.
I'm a big guy. I mean, getting out of that window is going to be somewhat of a challenge. I'm going to move the front windshield more than anything, but nonetheless, I have a plan. Right.
You'll be there going, no rapid takedown. I have no
I
distressing injury. I
self-extricated.
have no drugs on board. I'm going to walk to your stretcher with no long work.
Right.
You turn that on.
And
Yes.
Karen Doherty says it's required by state as equipment for all state on all ambulances. I don't know.
really?
I guess.
So
I don't know, Karen.
a window punch is required on every single ambulance?
So one of the nurses.
Even BLS? ALS and BLS?
I don't know. We'll see if she puts in a comment.
And is that in
in
every
New York
state?
or New Jersey?
I don't know, because
Really?
one of the nurses was also a paramedic with us who was working in the ER at the time, and she said there's window punches in the ambulances, and the physician vehicle was right around there. And she's like, "There's got to be one," and I'm like, "I'm pretty sure there's not."
I don't think I ever put
I
one in.
mean, maybe there is, but I don't know. It could have
We
been
don't fall
underneath
into
everything
840
else.
I mean-
first.
Most people who have like the Raptor shears, what's nice about those is that they have a seatbelt cutter and they have a window punch, already in them,
Right.
which is amazing.
Of course, your argument is that every emergency department should have one too.
Maybe, perhaps. You never know what's gonna happen.
Well, we've run out of all drugs. We might have
Exactly.
some piece of equipment in the emergency
Yeah.
department.
There's no back order on the
Anything
window
else
punches.
interesting pre-hospitally or in the ER?
I had one in the ER that was cool. It was very straightforward and easy, but it was a gentleman in his late 30s who came in, ate some Christmas cookies and didn't know they had peanuts in them, and he had a peanut allergy. So it was a true full-blown anaphylaxis that you see the whole syndrome starting every once in a while. They get IM epi, they usually improve. This guy was not improving. Pre-hospitally, he got IV fluids, Zofran, he got steroids, he got Benadryl, he got epi IM in the thigh, and by the time he came into me in the ER, he was hypotensive and 70s, 80s systolic. He was tachycardic. He was wheezing severely, both in all lung fields, and he was completely unresponsive. So he was very, very sick. And setting up to intubate, did a few more IM injections of epi, and then just realized pretty quickly, thankfully, we just have to start an epi drip on this guy. And that's probably the second time I've actually had to start an epi drip on anaphylaxis and have it continuously running. This guy, we admitted him to the ICU, and after about 2 hours, he was still dependent on about 5 micrograms per minute of epi.
Did you bolus epi or just drip it?
So
I know you gave IM.
Yeah. So initially
Because obviously IM doesn't work well if you're hypotensive.
Right. So initially I had push dose epi that I gave a few squirts while the pharmacist was setting up the infusion.
So you gave
And
like
that
10 mics at a
bridged.
time bolus?
Yep, 10 mics at a time. And it's funny that by the time ICU came down to evaluate him, his blood pressure was 120/80.
Of course.
His lungs were clear. He looked perfect. But at that time, he was still at 10 mics per minute of epi. And I'm like, well, look, we still have the epi on, and he looks like that. As soon as they turned it off, his blood pressure tanked again. So he was just a persistent, drawn-out anaphylaxis, and I thought that was amazing because I've never seen one that severe before.
Right.
No, I was about to, but he kind of perked up and woke up once we started the epi drip, and he started answering our questions.
So
And
I
all
assume you
I
had to
all I
search
could
what
get
you
out
were-
was peanuts, and it's like, yes, peanuts.
Right. So we know Benadryl's a silly drug, right?
Right.
That only works for itching and rashes. Does nothing for airway. Let me say that again. Benadryl does nothing for
Nothing for airway.
capillary leak in the airway. It's all epi. Solumedrol doesn't work well. Its mechanism is different in anaphylaxis for asthma and stuff. Sometimes in the emergency department we give H1 blockers. Do they really work in anaphylaxis? We give them, but who really cares, right?
The theory is there. I don't know how they.
And but Benadryl, oral Benadryl takes 100 minutes to work for anaphylaxis. We know that from our science, and I still don't know why doctors discharge patients with allergic reactions with Benadryl when we know Zyrtec has some superiority in several studies. And it's easier to take than Benadryl Q6 hours. But reach for the epi first, and then switch to IV if they're not getting better in the hypotensive.
That's the first time I've ever had to admit an anaphylaxis to ICU. In my experience, they've always turned around, even with 1 or 2 injections of IM.
No matter how bad they look.
No matter how bad they look, they turn around. And this guy, I think, like you said, hypotension. It just was not getting out of the muscle. You weren't perfusing, or the epi was not getting into the system quick enough. And it was pretty amazing though. Once we started that drip, he woke right up, started answering questions, and it's pretty amazing. So.
That's important to note is that we have a lot of therapies where we treat patients and they usually turn around with our first line, but it's always important to think what happens when that doesn't work.
Right.
So when it doesn't work, when he is not breathing, and you don't have to be like, oh crap, what do I have to do? You already know what your next step is going to be.
We all remember interesting cases of anaphylaxis. I still picture this guy. He filled the prescription. So when Levaquin first came out, he filled the prescription for Levaquin. He took 500 milligrams at home. He lived 10 minutes from the hospital. He came in. He was in anaphylactic shock. And as much as I tried to figure out some other cause of it, I couldn't do it. And the only thing he took, and it was right before it, was the Levaquin, and he was in anaphylactic shock. And how many times we write for Levaquin, give it a prescription, and send people home? And this guy would have died. He had persistent hypotension, sick as can be. I'll never forget this because we don't see this, but that was his anaphylaxis.
And when he finally woke up and I said, "Hey, don't you have an EpiPen?" What do you think his answer was? I couldn't afford it.
He couldn't afford it.
So.
How much fluid did you give him?
Oh, he got a couple liters, I think, by the time the epi drip was started. Once the epi drip was started, we didn't need as many fluids, but I'd say he was on to his 3rd liter by the time.
So the question is, if you had gotten him much better and were able to wean off the epi drip, would you have sent him home? Because this whole thing about how many epis before you can't go home. There's more literature about that for croup than there is for anaphylaxis.
I don't know. The way I was taught in residency we looked at a few articles in Journal Club. There's really no evidence behind this, but you always worry about the biphasic reaction. So the patient who comes in and is completely resolved, and then all of a sudden you're about to discharge them, they go back into anaphylaxis. I think that's about less than 2%. That doesn't happen. And the classic text question of that is the guy who had a peanut allergy, kissed his girlfriend, came in, and then the girlfriend comes back and kisses him in the ER, and she still has peanut butter in her mouth or something like that. Right. So, I think that's the only time you're going to see a re-exposure to the antigen.
I've never had a satisfactory answer from looking at any papers about this biphasic reaction, exactly when it occurs, what population it occurs in. Every time I read something, it's a little bit different. There are better reviews than others. But I think it's a phenomenon that does happen, but when I hear about it happens in 20% of people, I'm like, that's just crazy. It absolutely does not. It's a very small amount, that's all I know. But I don't think you hold everybody in the emergency department.
Most of them I discharge. They turn around, make sure they have an EpiPen, and go home. And there's, of course, the dogma, watch them for 6 hours. We don't know where the 6 hours comes from.
Right, that's totally made up.
So.
The same thing with ACE-induced angioedema, which we worry about all the time, which can obviously be on your ACE for 30 years, and then you have your reaction today. And there was a hospital in New York City that reported case reports a couple of years ago. I remember this, where the patient was watched in the ER to complete resolution according to their case report for 6 hours, went home, lost their airway, and came back dead. Right? Who of us watches 6 hours after all symptoms resolve after an ACE-induced angioedema? Nobody. Right? So this stuff can be really bad. And I've seen people in the hospital who got admitted with decent airways who progressed and lost their airway in the ICU. Right? I mean, ACE-induced angioedema is a bad thing. If you're on ACE and you're having angioedema and your tongue is swelling, always be very worried. Right. I mean, you mentioned tongue swelling. I think of differentials for tongue swelling.
Yeah.
Like from Dilantin to a bunch of different drugs to seizure meds to amyloidosis causes tongue swelling and stuff.
Yeah, that same night we actually had an ACE-induced angioedema as well, like about an hour before, and we don't have the scope in the ER. We had to call ENT to come down or come from somewhere else, and they came, and the vocal cords were everything was swollen in the back. Back of the throat, and she ended up going to the OR to get nasotracheally intubated. Angioedema, can be scary, but it's also so unpredictable. I mean, you get people that come in that have been having swelling for hours that just don't progress, and then you get some of these people that that do progress or their airways are really swollen to begin with. And
The other thing you can do, and it's a little trick, is you give glycopyrrolate just to drive secretions for some of these people. I've actually heard people, like, I read a case report recently about somebody nebulizing glycopyrrolate too.
Oh.
But you can inject it as well. It dries up. We don't carry it pre-hospitally, but it's a great drug to drive secretions.
Yeah.
Anesthesia's been using it for decades. So I mean, if you use extra secretions in your airway, just go push some glycopyrrolate, and the secretions are gone really quickly, and you can just keep redosing it. So I mean, it'd be great for like an epiglottitis. Anything else interesting?
Talk about the case that I sent you yesterday. We had a 30-year-old guy with a history of a spinal cord injury, so he's quadriplegic, and got called for respiratory. When they get there, he's stridor. You can actually hear him breathing as the medic is calling into medical control. Going through the assessment, she asked for to nebulize epi. And the medical control doc said, well, do you have racemic epi? She said, no, we just have 1 to 1,000. And she said, well, with that, why don't we just monitor and transport you only 15 minutes from the hospital? So the question was raised, should we be doing nebulized epi, even though it's not racemic, in that situation?
So, I mean, my response is sure. Right? I mean, we give nebulized
Epi for upper airway stridor. I mean, croup is a classic thing, but we give for other reasons, right? You guys have given a lot of nebulized epi for a lot of things, right? So if somebody's thinking about, and this whole thing about giving like 0.3 or 0.5, that's all totally made up, right? You give some, right? And then you give some more, right? I mean, there's nothing magical about those
I think
numbers.
in concentrated epi, isn't there a certain percentage of it that's racemic anyway? That's
Yeah.
absorbed better. I don't know what percentage that is,
I
but
don't
it's
remember
something
either.
high enough that it's significant it'll work. But all the I know several peds docs who Matt Harris included. Shout out to Matt Harris, who just uses regular epi because there's a certain percentage, and they all
Right.
know how to mix it themselves.
They all use regular epi, not racemic epi,
Yeah.
which is totally fine.
Yeah.
But for upper airway stridor, for almost any cause of it, and there's a whole 100 different things that can cause it, it's totally fine. And then that doc called me and said, "What do you think about this?" And I said, "That sounds good. I would do it." Because 15. I mean, people lose their airway in less than 15 minutes.
Mhm.
Yeah. What else? Anything else?
There's an interesting case this morning that I wasn't on, but I heard about it from some of the paramedics talking about airway stuff.
Is your green light on?
Yeah, can you hear me?
Yeah.
They were called for a patient who was in respiratory distress, and I guess somewhere in the history they got that the patient had like bilateral vocal cord paralysis, and he was kind of just like snoring and not really able to speak well, although he was satting in like the 80s, even on a non-rebreather. And I guess there was, I didn't talk to the crew, but I heard it secondhand. I actually spoke to the doctor who was in the ER, and they were, debating if they should try and intubate this guy pre-hospitally or not. They ended up not, and they ended up transporting to the hospital in a pretty short time, where I guess he just got sedated, not paralyzed, and ended up going for a surgical airway. They said they had looked with a camera before they went for the surgical airway, and they saw they could just see like a tiny little hole, which I guess they tried to put a bougie through but weren't able to. But my question was, if he's got bilateral vocal cord paralysis and we just paralyzed him, would the vocal cords relax? And then he could possibly.
So I've read some of this literature, and it does. It relaxes. I mean, this is like a chronic condition, right? Actually, there are people who are young who get trach because of this chronic condition, right? And if you're a little paralytic, they relax. The risk is you can't intubate them, but generally they're not any more difficult intubation than anybody else. So you can do that. You can also try, a bunch of like nebulized epi and other stuff to try and get the vocal cords to move again, because it's like acute on chronic condition.
Yeah, so they were saying, the ER doctor was telling me that, he said he wasn't the one who was primarily taking care of it, so it was also a little secondhand, but he was there and he was saying that they heard that the vocal cords hadn't moved in 8 years, that this had been going on for quite some time, so they were hesitant about paralyzing him, I guess. And then also when they looked with the video beforehand, but my initial reaction was just paralyze the guy. Like, I think that it should in theory relax it. Turns out the guy also had some tracheal surgeries, and it wasn't. I don't think it was so easy to get the surgical airway either.
Right.
But
Maybe he had
just
some
kind of-
tracheal stenosis. And it
Yeah,
was
so I think he had some tracheal stenosis, and then he may have had some sort of tracheal resection as well.
Right.
So
it
I
would have
think
been a
the whole
bad
thing
case.
was kind of a mess. It sounds like they said the guy's doing fine now, so they ended up doing a great job. But I guess the question is, do you paralyze someone like this who's got this? And I think that's that is the major turning point, I think, in this case, because you paralyze this guy, maybe the vocal cords will relax and you can get a regular airway in as opposed to having to go do a surgical airway. But I think if you, I guess to do a surgical airway while the guy is just sedated is probably a little bit safer, perhaps, for the patient. Depends on
I
how
think
good
so,
you
because
are
sometimes
at
you just
doing
can't
it.
oxygenate no matter what.
Right. So it sounds like he was somewhat oxygenated. But yeah, then it was just like, I don't know if they.
But my understanding is like when you bag them, the vocal cords still move and still open. They just don't move by themselves because you lose airway pressures.
Oh, right, yeah.
So that's what usually when you go with your laryngoscope, they're flopping in the wind.
I mean, but one of the things that you have to think about is that at the end of the day, I mean, most importantly is that, RSI, obviously you're looking at the vocal paralysis, but also it's, RSI, why does it improve numbers? It's because, the patient's not fighting you. If you sedate the patient, you're going to have to use a significant amount of sedation to have the patient not fight you, to put the blade in. So if you get the blade and the patient's paralyzed, at least you're able to now successfully at least visualize your anatomy and without having to fight the patient a little bit or having to kind of go in multiple times. Now you're going to cause trauma, So being able to RSI somebody and paralyze them, now you can actually put your blade in without any fear and take your time. Now being able to visualize your anatomy and actually pass the tube in. So I think in order for you to effectively have a first pass success and being able to intubate in the first time, especially in a patient that is kind of tricky, RSI might be beneficial. That being said, I mean, this is a tricky scenario because now you paralyze somebody, you may not be able to get the airway, and you may have to now ventilate, which if you can't, you have to go to surgical. So I mean, it's a kind of a, it's a double-edged sword. But I think in this scenario, you would want to optimize your situation, or if anything, appropriately sedate the patient to a point where you can actually now pass the blade in without them fighting you. So, I think we do a bad job in doing that, but I think now with ketamine, we really have a really good drug that doesn't bottom someone out, with the sedation that we're giving, and there's no really ceiling to it. So we can give, I've given a gram to 2 grams of ketamine, in an awake intubation, but that's the right way to do it. You start off with 200 and you continue to give more until you give enough to where you can appropriately approach the patient and intubate them. The problem is we're giving like baby doses and we expect that the patient should be, sedated, and that's not the case. I mean, how many times have you seen ICU giving, 2 milligrams of Versed to intubate the patient? I mean, that's just crazy, But meanwhile, we're giving up to a gram, sometimes 1,500 milligrams of ketamine to intubate. And I think that's where it's more appropriate, and I think, to be able to do that. So if you're going to do an awake, appropriately sedate, but if not, if you want to increase your first pass success, obviously RSI is important, but then know that, your next step, just like Navid said, if your first, attempt doesn't succeed, what's your next step, what's your backup, and then ultimately be comfortable with the surgical airway.
Yeah.
I don't know, if you lightly sedate though, when you're intubating these patients, you can tell them, say, don't bite down, and maybe they'll listen to you.
Right.
That's usually
Right.
how it goes when you get them to a person.
Right. The other thing I was thinking is I have heard that CPAP is very effective in people with
Yeah.
vocal cord paralysis too. But sometimes you have to, if you're in the hospital, you start BiPAP instead of CPAP, you can start like 15 and 10, maybe like a higher pressure, and it may be more beneficial. So because then you're putting pressure because of forced clots, maybe forcing open the vocal cords.
Yeah, I guess it's something that we don't see too often or really probably think about. But, I mean, when they told me this guy had bilateral vocal paralysis, they asked me about it. I'm like, I remember reading stuff about it a while ago, but it's not something that's readily available in my brain, at least, because
Right.
we don't see it all the time. And I think just knowing about it and hearing about it, and all these weird kind of cases, like what's the best way to kind of approach it? Because there is a chance, especially with our 7,000 viewers, that someone is going to see this next week
Right. Or today.
or today.
Or during this conference. All right. Well, why don't we go into the articles? So, Mike, you want to start off with what do you want to do? TXA, ICB.
Of course,
So-
anything TXA, you want me to talk
So
about it?
kudos
I
to
got it.
Dr. Michael Kaur. I was waiting and I saw the gems in print right before coming over here, and sure enough, somebody walked in and showed it to me, and we are the TXA article in Gems. Dr. Kaur is the first author, and so it's a critical appraisal of TXA, and it's not just TXA in trauma, it's TXA for everything. So if you want to learn every piece of data about TXA and the history of it, except for maybe a few studies which are still to be determined, haven't come out yet, go to this month's GEMS.
Yes, yes. Maybe we'll review it in Journal Club sometime soon. But I don't know. We kind of talk about TXA enough. I think. Do you think people are starting to get the hints?
I think that if you are somewhere right now, wherever you are, and you do not have TXA in your hand, you probably are not prepared for emergencies.
Yeah. Like I said, I carry it with me wherever I go. So, and it just, I recently over Christmas vacation, I was home, had a family member with a terrible nosebleed, I had TXA right there ready to go. So just saying, you have it with you all the time. So.
You just had two.
Is your green light on, Chris?
Now my green light's on. We just had somebody who we were going to have to intubate potentially with bleeding from a tongue ring.
Bleeding from a tongue ring,
from
like
a tongue
something
ring,
was just
and-
put
and
in a.
she, and she was having just copious. She had basins full of blood that she was spitting up, and
Wow.
they were trying direct pressure. And then it was like, she's bleeding a ton. She's not going to be able to protect her airway. So in a last ditch effort, we did TXA topically. We paged ENT to come down. We were all set up to intubate, and she'd stop bleeding within 10 to 15 minutes.
You just put on like
He
a.
said, "Why did you call me?"
Yeah, exactly.
And then did you just put on like a 2x2 or 4x4?
Yeah, just a 4x4 that we moistened with TXA, put it directly in, and then there was a lot of clot formation that was in the area. She stopped bleeding.
And this was just and you took out the tongue ring, right?
ENT together.
Oh, so you left the tongue ring.
Yeah.
And so somebody had
It,
just.
it wasn't even coming directly from the tongue ring. It was just lateral to that. So there was some questionable, like she hadn't just had the ring placed. It was placed a couple weeks ago or something. But there was this other oral trauma that she sustained that was adjacent to the actual insertion site.
Like
of
at the
tongue
same
ring.
time? Like recently? Wow.
How much TXA do you put on that?
You just take the gram and soak
I
it.
think just the whole
Yeah.
thing
And
saturated.
then the answer is who knows.
Most studies, like for epistaxin stuff, they take 500 milligrams. So they just take half the vial and soak it in a cotton pledget or pledget, however you pronounce that, and then they do that. But I usually just take the whole gram and soak it on a piece of cotton. And put
We
it
have
up.
dozens of these cases of people with nosebleeds and people bleeding from their gums and people bleeding from their scalpel. We just put some topical TXA on, didn't ever even give an IV dose, and they stopped bleeding. Much better than other devices we've used over the years.
Yeah.
So, all right.
So this one we're going to talk about today. I just put a picture of the article title. It's just a statistical analysis plan for TXA for hyperacute primary intracerebral hemorrhage. So the TIC2 trial. This is just their statistical analysis, but they do talk a little bit about the background of how they're enrolling patients and everything. And they were recently enrolling up until December 30th, I think was their last patient that they enrolled. So over the next few months, we're probably going to start to see a number of studies coming from this data. They were anticipating 2,000 patients enrolled, but last I heard, they had far more than that. So we should hopefully get some good numbers. So the rationale behind doing this study in theory is you have an intracranial hemorrhage, right? A primary spontaneous intracranial hemorrhage. So that means there's a bleed and we don't have a direct cause like a tumor or an aneurysm or something like that, right? This bleed just came out of nowhere. So those are the patients that they're looking at. And this trial was pragmatic, very good word to hear in a trial, phase 3, prospective, double-blinded, randomized, placebo-controlled trial. All those good words you want to hear in a trial. So more so, I think, the pragmatic. So that means in a clinical setting, they're going to be looking at patients. So you're really not going to be too strict with your inclusion and exclusion criteria, right? Because you want more patients and you want it to apply to a broader population of patients. So what do you worry about with these intracranial hemorrhages? Usually it's the hematoma expansion. So what happens when you get a bleed in your head? It bleeds, it expands for a while, and then it contains itself. It's self-tamponading, self-limiting, right? What happens I think they say it in here somewhere, but other articles cite it, in a certain percentage of hematoma expansion. Yeah, it's up to 18% of hematoma expansion, re-expansion, is after the initial bleed tamponades and contains itself, several hours later it can start bleeding again, and that's what kills patients because they slip under the radar, they think that they're stable, the bleed is stopped, then 18% of the time it'll start bleeding again, all of a sudden the patient's unresponsive, not breathing, and they've herniated. So that's really what you want to try to prevent with this. So they, they talk about all the trials that we've talked about before in our journal clubs. They mentioned Crash 2 and that mega trial and the good outcomes that they had, also with no increase in vaso-occlusive events, as we harp every week. And they also touch on a
Say
few...
that again, no increase in vaso-occlusive, because you
Events.
can always find some small paper to show slightly higher increases, but do they
Right.
have similar injury severity scores, but no increased risk in the biggest trials ever in DVTs and PEs.
So in the realm of intracranial hemorrhage, this is actually not the first trial, not the first study that has looked into this idea. So they cite a few papers. I was only aware of one that we've talked about before. In 2002, you have the Journal of Neurosurge that came out with a really small randomized controlled trial where they demonstrated a reduction in rebleeding or re-expansion hematoma.
Was
and
it 2002? I
decrease-
always forget that date. It was 2002?
Yeah, I pulled it up.
So, and
That was
what-
Journal Neurosurge 2002.
Yeah, and we always ignore that trial. For some reason in medicine, we've chosen to completely ignore the trial. But yet we do have data to say that it is health. You want to talk about the trial for 1 minute?
Sure. So really quick, that was in Journal of Neurosurgery 2002. That was Hillman et al. Title was Immediate Administration of TXA and Reduced Incidence of Early Rebleeding After Aneurysmal Subarachnoid Hemorrhage. So this was prospective, randomized. Basically, so they looked at all their demographics of patients. I forget how many exactly they had. 251 patients that were randomized ultimately. So that's not as large as this study we're talking about now. That's over 2,000 patients. That's the big significance. And they did the demographics. 90% of the patients were to an appropriate center within 12 hours. They really looked closely at that. But the main thing is the reduction of rebleeding rate from 10.8% in their population to 2.4% after TXA was given. So significant, very significant. And 80% reduction in the mortality rate from early rebleeding with TXA. So this was a very well done study, and unfortunately just did not get the press that it needed. I don't think if you walk into any ER and you ask any ED attending if they had a spontaneous intracranial hemorrhage within the last couple months, which I'm sure they have, did they give TXA? They're like, what the hell? Why would you do that? I just heard that you can give it for nosebleeds. I don't know if you did.
So we ignored a great study.
We ignored it.
And then we ignored it for 15 years, right? It makes
Right.
you wonder. And I normally don't include studies just for statistical analysis, but this is a big deal. This started in 2013. They're stopping patients, or last month in 2000, or the database is locked in early 2018.
Yeah.
This will help answer some. I hope this will give us definitive answer on this question. But maybe every intracranial bleed should get TXA.
Right. So yeah, they started enrolling. It was a 12-month startup phase. The really limitation. So they had to get approval to expand their enrollment period up until just December because they were having a hard time enrolling internationally. Not sure if that matters, but they were trying to get as many sites, as many different settings as possible to include the validity of the study because you can apply it to more populations. So. They talk about their methods and everything. I think the most important thing to take away from this this preview article is basically the primary outcome is going to be death or the dependency or the decrease of the modified Rankin scale at 90 days. So any of the neurosurgery literature, that's the indicator that they're using to as a patient-oriented outcome. So that's basically the best we have right now. But death, more than anything, your best patient-oriented outcome. So. Let's see what else. So I think that's pretty much it. I highlight, the references that they included. They had a few more studies, reference 8 and 9 if you're looking at the paper, and those were the only other two randomized controlled trials that they mentioned. Very small studies that showed a reduction in the size of the hematoma that was measured on CT after TXA, and another one was decreased mortality as well. So.
It's funny, we used to think TXA was contraindicated in subarachnoid hemorrhages. And we may find out that not only is it not contraindicated, it's indicated.
Yeah.
So it might be easy in the emergency department, particularly after this, that we should be giving TXA for head bleeds. But what do we do with a pre-hospital patient who has isolated head trauma where we don't know if they have a bleed on their head CT versus just a concussion?
Mm-hmm.
Are we going to order TXA?
I wouldn't think it's indicated unless, I don't know, unless there are hard signs of traumatic brain injury, an unresponsive patient, somebody who's having a seizure or something like that. I mean, seizure after head trauma almost always means some kind of a bleed, at least in my experience. I don't know if there's anything to back that up, but, you know.
I don't know if that's true.
Yeah.
I mean, we could look that up and try and answer that
Yeah,
question.
try it. We can do a clinical pro
I mean,
on it. Actually, that is
I-
true. They just talked about this on a podcast recently.
Particularly
one
in children.
one seizure is fine. If you have
Yes.
recurrent seizures, then you
That
start
sounds
to worry
good.
about
That sounds
head bleed.
right.
That sounds about right. But,
So I would say the incidence of an isolated seizure with an intracranial bleed after a head trauma is probably exceedingly rare.
right. But recurrent seizures and neurodeficits and altered mental status probably just increase the risk. So I don't know. And then the other question that's going to come up, which we've looked at papers on that before, is what about the patients who had a ischemic stroke? They got TPA,
Yeah.
and then they started bleeding. This
Yeah.
is a perfect antidote to TPA. Too many letters and everything going around, but give TXA for TPA bleed, right? So it completely, directly irreverses everything that TPA did, right?
It's a perfect drug to reverse it if you bleed. And we know the incidence of bleeding after you give TPA for an acute ischemic stroke, according to the NINDS trial, is 6.1%. But if you believe the Cleveland area experience trials, it was over 15%. So when the community hospitals give TPA for strokes, their bleed rate's 15%. When it gets done in more academic centers, it's 6%. But you have a perfect drug now to reverse it. It might not always work, because people who get head bleeds after TPA tend to do it generally worse than the average population. But nonetheless, it may be a perfect drug.
And Ed Bowder just commented and said, how do we feel about just giving TXA empirically to fall victims on Plavix or aspirin or something, or blood thinners, something like that?
Right.
They're at a significantly increased risk of bleeding.
So that's what I was asking. It's a hard question to answer, because certainly if you're concussed, you're typically altered for a transient period of time, and that's the same thing you have when you have intracranial bleed. Most people who hit their head who are on Plavix or a 10A inhibitor or a direct thrombin inhibitor have no bleed, right? The average person who hits their head on a blood thinner has no bleed.
And
So
in
you
fact, trauma centers roll their eyes whenever we bring in a patient, who fell.
Well, only in the United States, and only some people. I don't know. It definitely means we'll be giving TXA to a lot more people who will have nothing wrong. And I'm not saying that's a bad thing. I'm just saying I'm just not sure.
But then what if somebody, what if a certain percent of the population have existing DVTs at baseline or something that are undiagnosed, and all of a sudden they go to a hospital and get diagnosed? They might attribute that to
Or they
TXA.
just have a hypocoagulable period of trauma too, where they're at risk for DVTs and PEs, because we put them to bed rest, and then we'll blame TXA on that too.
Right.
I don't know. I think probably the baby step is to come up, if this study shows a benefit, which hopefully it will. I think the first step is to come up with a criteria to say, if you have these hard signs before a CAT scan's done, this is where TXA is indicated, so we're all using the same playing field. That's what I would suggest, although people always argue that this hard sign, is only so sensitive, so it's not perfect.
Right.
So we'll come up with an imperfect criteria and give TXA pre-hospitally. I mean, what do you guys think?
Yeah, I don't know if there is an answer. Yeah.
The real question, I think, is in the ER. Okay, now we have a CT and we have a bleed. Does this need neurosurgical buy-in? I mean, I guess it kind of does. But what should we be pushing for? Should we be getting angiograms right off the bat, and then when we see a bleed right on the table to is this aneurysmal or does it matter?
I mean, I think we should. I mean, I think the answer for subarachnoid is easy. Subarachnoid, you do a CTA on the table.
Mm-hmm.
But I think that anybody who's heading to the table for a head bleed, except minus a few people with a low index of suspicion, should get a CTA while they're on the table. It just kind of makes sense to me. CT head, CTA, bam, no questions asked. It's easier than bring the patient back.
Right.
It's probably a little more challenging to read a CTA for a novice radiology resident, right? But it's still important, right? For almost you're defining anatomy. Who just figures out there's blood without defining anatomy?
Right.
So, why not just give as early as possible when we know from, although it was trauma-based, we know from the London meta-analysis that for every 10 minutes you delay, survival goes down by 15%. Did I say that right? For every 10 minutes you delay TXA, survival goes down by 15%.
Yes, or it's the other way around. For
It's the
every
other way
15,
around.
every 15 minutes that you delay giving TXA, survivability, or the TXA benefit, the death benefit decreases by 10%.
So it's the argument for, especially with longer transport times, for just giving TXA even without a CAT scan. I think that London study helped us prove TXA really is a pre-hospital drug. You don't just wait for them. 30 minutes is too long to wait to get to a trauma center. And it's 30 real minutes, not like my ETA is 30 minutes.
Right.
All right, that's good. What's the next study?
And then pre-hospital, it's also just so much easier to give medications because you just have it there. It's not,
Yeah.
You don't need a Pyxis machine. You don't need to go on the thing. Everything is just readily available. You think about it, you have it in your hand within a second.
Yeah.
It's just so much faster. Because it's the same thing. Like sometimes when these paramedics come into the hospital, they'll say, "Oh, for a seizure patient, I remember, this was one case where they came in and they had their Valium in their hand with them, and while they're waiting to be triaged, the patient's seizing again. And for us to go get that Valium, we need to find a nurse, draw it
Right.
up, whatever, and then they just had it in their hand and were able to get it right away. And it was like, great.
It's one of the 5 most dangerous lines a console doc says to the paramedics: call me back if. Right? There's no such thing as call me back. Call me back means I will probably never hear from you again because you'll lose a cell signal and I won't be able to call back. It's just like we think in the ER. Don't piecemeal. I got one shot of doing this. Get it right the first time. And sometimes you got to go back, but don't piecemeal. All right, what's next? Drew, you want to do one?
Sure. Talk about the updates to the TCC Tactical Combat Casualty Care Guidelines. They basically offered a update in August 2017 to kind of expand on some of the definitions and really hone in on extraglottic airways, kind of their expanded definition of what we probably would call supraglottic airways, but they're kind of including all the devices. So they talk about, this is just kind of a guidelines update, so not really a research article. When they talk about the guidelines were originally published, the Tactical Combat Casualty Care Guidelines were originally published in 1996, and they recommended using a laryngeal mask airway. That's kind of what they recommended in securing the airway during the tactical evacuation phase, so basically the pre-hospital phase. And then since then, they again updated the guidelines in 2012, where they reaffirmed their support for the use of the supraglottic airway, but they didn't recommend a specific brand or specific device because there wasn't a lot of available evidence at that time. However, this guideline update does actually recommend that the current evidence suggests the iGel, which is the intersurgical complete respiratory system that's the manufacturer. They recommend that the iGel it performs as well or better than the other extraglottic devices or supraglottic devices that are available, and it has the other advantages of ease of training, size to weight ratio, cost, safety, and simplicity of use. The main difference between the iGel and the other LMA is the LMA, most of them use air based, so you got to fill up the cuff, you've got to monitor the cuff, and in the arena of especially tactical evacuation, you're talking about helicopters, or you're talking about transport medical planes, where you have the air-filled LMA, you have to actually monitor the pressure with the manometer to make sure you don't cause too much pressure. Because you have that increasing pressure, it puts a lot of pressure on that pharyngeal space, and you can have neuropraxia of many of the nerves there in the oropharynx and hypopharynx. Compared to the iGel, instead of air in that mask airway, it's filled with gel, so it doesn't actually expand that much. So I think that's a pretty interesting, bold recommendation of a specific device that they feel is a lot better, and there's definitely some big advantages to not have to manage the pressures and not have to kind of guess on how much is really needing to be in there, and still have a good outcome. There was a couple of other things that they kind of mentioned as guidelines, and just for completeness, we could mention them too, that for people that are unresponsive, right, a laryngeal, supraglottic airway or an extraglottic airway is pretty easy to use because they're not really fighting you back. However, if you're not sure if they're on that line, maybe a nasal pharyngeal airway is better means and more tolerated means of securing the airway in people that are kind of on that line of unconscious or unresponsive. The guidelines also add the use of suction to adjunct the airway, right? We don't just need to shove it in and hope it works. We can optimize and make it the best. They clarified that we don't need cervical spine immobilization if there's just, gunshot wounds to the chest, right? If there's no other blunt injury component, they weren't thrown from a vehicle, there wasn't an explosive, that we don't need to put on a cervical spine collar because it's tradition and we want to keep the tradition alive. They also reinforced that surgical crikes don't have to be performed just because they're unconscious, but they should be readily available for people that have burn injuries. It's kind of, I think they're pushing for their use earlier in the management rather than later in there. But I think that the real interesting takeaway is to recommend the specific eye gel, which we've seen. I haven't ever personally used it, but looking at the device, they look like it would be a good
I put a
alternative.
picture of it up in so people can see what we're talking about. And just to say, we have no financial conflict of interest or disclosures. We don't endorse any specific, device, but this is the one that they talked about. So we put a
Informatics
picture.
work for programs that are using iGel that also work for us. We love the iGel.
I like the iGel too. I mean, I think there's some decent literature that talks about superiority of iGel as an alternate airway. It's more expensive, right? I wish it was less expensive. I think in order to buy a product that's more expensive, the literature has to be very robust. And I think there is literature there. I wouldn't define it as robust though. I don't know, Bob, you have any thoughts about that? In Czechoslovakia published one of the first papers, and then somebody in Florida published a paper about, I think it was Miami Beach, about iGel's superiority. Yeah. And I like them a lot. They're just definitely more expensive when we price them out.
I think it all comes down to cost at this point.
Yeah. And again, I think we would support it more if the literature was overwhelming, that more people walk out of the hospital alive. But you'll never find that with an alternate airway, right?
And this is also in a special subset. This is in people that are being flown out of a casualty area, so that it's kind of a different thing than people that are going to be primarily in ground transport. That's a fact that is considered in the guidelines.
Right. Plus, we're big supporters of paramedics intubating based upon the 3 trials that came out in the last 6 months: the Taipei study, the Protect 3 trial, and France and Belgium's ADNET study, which is yet to be published. I think we now can safely answer the question, the last couple of months especially, that it's better to intubate versus do an alternate airway. So now we'll do even less.
One of the bigger advantages, additional to TTC, but pediatric population, the iGel is really good. So you commonly will see even anesthesiologists who do these conscious sedations on kids for MRIs or what on kids. They use the iGel very frequently.
Right.
It's something that's easily deployable. Certainly less trauma, but you could definitely. Sometimes you have issues with securing it. I think in the pediatric population, but there are commercial devices that secure the iGel for adults, which would give you less problems for the most part. But I think overall, I think it's a great device. Our initial question was temperatures, what spectrum of temperature can this kind of really withstand?
Yeah,
especially because it's a gel, and how does it really kind of conform to, when you're in really freezing temperatures like currently that we have in New Jersey. So, how would that really perform in that kind of environment? So,
because Czechoslovakia did the first study, I think, so
Yeah.
we thought, and it's very cold there, so we thought that it was only going to be in the cold temperatures. And then
Right.
I think maybe it was Miami-Dade who.
Miami had a study as well that did iGel. They had pretty good, and that's pretty hot there and humid there. So I guess you see both ends of the spectrum, but at the same time, I think it's a really good extragalactic device. But especially for pediatrics, I think it's a really good device for being able to use and be able to drop in pretty quickly and be able to secure some type of SGA.
Right. All right, that sounds good. Anything else, Drew? All right, Alex, did you have a study?
Yeah, I have either hyponies in children or the delays, paramedic experience. So,
How about the paramedic experience?
what's that?
How about the paramedic experience?
That works for me. So, the paramedic experience. This was published in the pre-hospital emergency care. This is a study coming out of San Antonio. It's the San Antonio Fire Department, and this is a 1 year, pretty much January 2000 14 to December, so they had 1 year of they have 1 year data. So essentially, the question was, people that are they get repeated exposure to events typically perform better. It's kind of muscle memory, if you will. So this article is looking at paramedics. Does the experience of more exposure to out-of-hospital cardiac arrest improve performance? And they were looking at this as sustained return of spontaneous circulation. So 5 minutes or more is what they defined as their sustained ROSC. So that was kind of what they were looking at. This was a QA retrospective analysis, QA, QI data. And again, it was January of 14 to December of 14. The San Antonio Fire Department, this is performed in their setting. Not every system functions in the same way. They actually have a four-person fire company respond to all out-of-hospital cardiac arrests, and they also have 2 dual paramedic staff units also responding. So you have a pretty large crew responding to out-of-hospital cardiac arrests. You have a lot of hands on deck. It talks about the pit crew model that they use. So essentially, you have one lead medic who is truly just performing, just running the code, if you will. And so that is different than a lot of models where you're shorthanded. You may not have multiple ALS providers available at one scene. So this was looked at again with a little bit potentially different model than all, but they were using the 2010 ALS guidelines, ACLS guidelines. Their inclusion criteria was pretty much all out-of-hospital cardiac arrest where resuscitation was attempted. The patients that had DNR and that were not included in the study. So again, their primary outcome was whether or not ROSC was achieved, and that lead medic was the one who was being evaluated. The other things they looked at were survival of hospital admission, survival of hospital discharge, and then the neurologically intact survival, which is the CPC scoring. So what they did was, out of all the patients that they had in this study, they ended up using the paramedics and separated them into 2 groups. So again, it's only the lead paramedic, not all of those that performed the resuscitation. Just the lead medic was the one that was put in either low or high in terms of volume. So the paramedics, they were dichotomized into 2 groups. One of them was a less experienced group and a more experienced group, and they set 10 out-of-hospital resuscitations as their marker. So less than 10 was less experienced, and then greater than or equal to 10 were the more experienced paramedics. And again, this is more experience in terms of exposure, not necessarily in terms of years on the job. So what they ended up doing, they had 1,145 cases that met criteria throughout that 12-month period. 343 paramedics were actually served as lead paramedic during this time. So there were 120 of them in the less experienced group, with 223 in the more experienced group. And essentially what they found was that the paramedics in the more experienced group had a higher percentage of sustained ROSC. So it was 28.9% for the more experienced group and 22.2% for the less experienced group. And again, that's just for sustaining ROSC. What it turned out was they didn't actually, all the secondary outcome measures, survival to hospital discharge, neurologic improvement, there was no statistically significant difference. So obtaining ROSC was one measure, but in terms of improvement on survival was not found based on paramedic experience. So essentially what they were looking at was, by having this exposure and having more experience, does this allow these paramedics to develop more muscle memory, become more proficient, and therefore improve outcomes? So the study found that you achieve ROSC more with more experience, and this can potentially, you can extrapolate this to serve as, for those paramedics or those team leaders who may not be getting that kind of exposure due to the volume wherever they work, does supplemental training come in to kind of help, whether it be simulation cases, constant review? Will that help supplement that lack of experience or exposure, if you will? So it's talking about doing this on an annual basis. It mentions potentially doing this on an annual basis for the paramedics that do not do this at least 10 times. So again, there's limitations in the fact that it's just one area in one system, and it was for a 12-month period of time, and that the other thing to take away from this study was that although we had a higher chance of achieving ROSC, they actually did not have any impact on neurologic improvement or hospital discharge. So I think it's I think it's definitely something to entertain in terms of, can we use education, simulation labs, whatever it may be, to help supplement that lack of exposure, especially for those more rural settings or settings where paramedics may not get the volume that would make them feel comfortable.
We do have a question from the stream. Just can we assume that that the lead medic was always the most experienced rescuer on the scene?
It's hard to say from the data that was presented. It's hard to be able to take that away.
Right.
And especially the other thing with this article is I didn't specify in terms of years of experience. So an experienced medic, you may have someone who's been doing the job for 5 years in a rural area who maybe sees 2 resuscitations a year, as to someone who's been out for 2 years and sees 20 a year. So
we could study this. It might not be that hard. We could take medics and we could give them like an experience score, right, based upon how often they work and the number of years they're working for. Maybe just even in the last couple of months, and then we can look at their success rate on procedural skills. I mean, this was anytime somebody does something first, or a reasonably big study like this, it's great. The only difference they found was in sustained ROSC. There was no difference in more experienced versus less experienced in survival at the hospital admission, survival at the hospital discharge, CPC scores, or average dose of epi. Their confidence interval for sustained ROSC was not too bad. It was pretty narrow. How do they define sustained ROSC?
5 minutes.
5
or
minutes.
greater.
5 minutes or greater.
Yeah.
So this just seems a little strange to me, doesn't it? So more experience gets you sustained ROSC for 5 minutes or greater, but nothing else. I mean, you could spin this study however you want to, but I would do a study to look at does experience let you pass the tube quicker? Or does experience make you have less bradycardia, hypoxia, or hypotension? Or does experience let you remember to put high-flow nasal cannula on more frequently? Or does experience let you get peripheral IVs in easier, or EJs in easier? That's what I would do. I would look for something like hard. Sustained ROSC more than 5 minutes, but not leading to hospital admission, hospital discharge. You could spin it to say there weren't really better outcomes with more experience.
Well, and I mean, more experience here is just based on volume,
Right.
or exposure, not necessarily actual time in the position.
We could do this study.
What about variations in viability of the patient, though?
Yeah, absolutely.
You know, at least we're not comparing apples to apples with all these patients. If you're a medic who works in a much more rural area, even if you have the same volume, it's going to be, your
Right.
response time is going to be greater. You're going to be encountering patients who have longer downtimes. So,
Well, I
And
mean,
their rate of ROSC
factors
was
here.
humongous also. I mean, 1 in 5 patients are.
they took care of
You're
confounding
finding it as 5
variables.
minutes, though.
They took care of confounding variables with type of rhythm presented, race, traumatic arrest, public AED use, bystander CPR, witnessed arrest, and gender of patient and age. They were all, it's like everything was similar. Yeah, it's interesting, but we could do the same study. Why don't we do the same study and just come up with a formula for how to define experience in a pre-hospital setting, right? And you define it by how often you're doing the procedure, because what else really matters? Not your history or your physical. You know, could you get the tube in or not? Could you, hypotension, hypoxia, nasal cannula, high-flow nasal cannula use? How about PEEP valve on BVM? Stuff we know that matters. Was the first rhythm? What was the time to the first recognized VF and the first shock? Like, that stuff matters. Like, objective findings, and see if experience matters, and if it does or doesn't matter, who does it matter in more? Does experience matter in men who are 80 to 90? I'm talking about the patient versus.
It's a hard job to retire from.
Right. I don't know. I think that would get a lot of attention, right?
And it kind of scares me though, because then you start scoring paramedics you might scare them away from the profession. Say, oh, you can only, then, you know, let's say EMS agencies
Too
might
late.
adopt this score, and then they'd say, oh, you can only work for us if you're 80 or better. And then patients, they get a hold of the score. They said, oh, the paramedic that took care of my dad was only an 81. Oh my God.
Right.
And then this score will be translated. There'll be a doctor equivalent score. So now every ED physician's going to get a score. Oh, this doctor's
So-
only a 78.
I see what you're saying. I mean, maybe the solution is to tease out what the best kind of experience is.
Yeah.
Like, is the best experience somebody who, I mean, can we find out people who go to more journal clubs with clinical experience do better
Yeah.
than people who don't? So maybe EMS will mandate that more people go to journal. I mean, this is how we change things in medicine, right?
Right.
You have to do all these
You could
online
even-
courses.
You could even take it to the amount of CEUs somebody gets.
Yeah.
You know, people that recertify at minimal amount of CEUs versus people that have.
Right. So there might be so many confounding variables to that. The people who recertify with more CEUs, are they better because they're more academically interested in everything, not just, you
Right.
know?
Right.
And if you were commenting full-time versus per diem might affect that. And then same thing happens with doctors, especially surgeons. So that's one.
Well, right. We always talk about this, you know, if paramedics don't intubate a lot, is it okay that if two paramedics show up that one can intubate you and one can't? Because one intubates one patient every year and the other one intubates a couple of times a week. And the answer is, isn't exactly the same in the hospital, that, you know, the care you get is going to be based upon who's taking care of you when you show up, and that, you know, variances in care are like incredibly remarkable.
Oh yeah.
Yeah, besides, if only the more experienced intubator was allowed to intubate, then those are the only people ever gonna have experience intubating.
Right.
Right.
I mean, we think about this with residency training and everything. I mean, they've done studies on like first pass success based on different levels of training and everything. And I mean, intuitively it makes sense to also that the more experienced person will do a better job of the procedure or recognize what's going on and come up with different ideas, assuming
Yeah.
they're learning. But everyone's gotta learn and, you know, to be able to progress and
Right.
advance in their careers and care.
But isn't it more experience plus the X factor? And the X factor might be how much you're reading when you're not at work, and how many journal clubs you go into, and what you're paying
Right.
attention to. There's some other factor, or else these, you know, older people would be the best at everything.
Right.
And I mean, the best at everything is experience plus that education aspect factor. It's just hard to have both, and you don't see it. You
Yeah.
don't see it that often.
That's true.
And then at what point in time does that fall off?
Right. Although I guess the argument is it could never need to, right? If we're all working 100 hours a week, maybe you never fall off the curve.
Yeah, I mean, the other thing I could think of is the person's comfort level with said procedure. I mean, people that are less comfortable for whatever reason are likely, have more fear, anxiety, whatever it may be, and can that potentially impact their success rate in whatever the procedure is? For intubation, someone who's done one intubation is likely to be much more nervous and anxious about doing that rather than someone who's been doing this for 20 years and intubation is just another day for them. So I guess I'm engaging that too.
Yeah, there's certainly a lot of papers out there about paramedic skills and when they decline.
Mhm.
But the question is, how do we do something a little bit different? I mean, I was wondering, we're one of the unique states of 2 paramedics in every ALS vehicle. I mean, how do people get to decide who intubates the patient, right? I mean, what really happens? If 2 paramedics, who's really making the decision? Is it more likely that, if I give you a crew and name you 2 people, could you tell me who's more likely to intubate?
Probably.
Right. So when nobody's looking, how are people deciding?
How are they? There's no policy for how they decide. They're going to decide as partners. Maybe they're taking turns.
Right.
Remember, we're in a unique system in the sense that our partners are always partners.
But it's probably not 50-50. Wouldn't you agree? Like almost every crew together.
No, I think that there's probably crews where one has a much higher comfort level with intubation than the other, and the one with a lower comfort level typically defers. But I don't think that's the common equation. I think that more often than not, they're probably taking turns. Or
And-
maybe they have an agreement, whoever's charted is the one who does the intubation. It could be anything.
And now with video laryngoscopy, it might be even more interesting to see who wants to try that first. I bet people want to say, I want to intubate because I want to try this. Because it's a new skill.
I mean, as a clinical manager, I go on the road a couple of days a month, and you better believe that the first opportunity I had with my partner to use VL, I was the one using it.
Right.
I said, listen, you're going to be out here a lot more than, you're on the road, 15 days a month,
Right.
if not more. I'm going to take the first crack at using it. So, I mean, those are things that come into the equation also.
Right. There's got to be some variation of this. I mean, it means pre-hospital emergency care. There's got to be a variation that's low-hanging fruit that we could do pretty easily without offending anybody.
I do think it was cool though that the way that they have like one paramedic who's in charge of it and then assigns the different roles to the other people. I think just having worked in various ERs, and when roles are defined and everyone knows exactly what they're doing, the resuscitations run much smoother than when things are all helter-skelter.
When I used to teach internal medicine residents handling cardiac arrests in the hospital. I stopped about a year or two ago, and the 10 lessons to learn, number one was everybody in the room should know who the team leader is. I should whisper into anybody's ear, the lowly medical student sitting in the back of the room, I should say who's in charge, and everybody should know who's in charge. And when that role changes, everybody should know how that role is changing. It's the biggest mistake we make. This, rule number 2 was nobody should ever raise their voice, but everybody should know who's in charge. And how frequently, if we walk into an emergency department, and say who's running this code. I mean, it's easy if you're a hospital with one person, or 2 people in the cardiac arrest. But when there's 10, which happens in teaching hospitals, who's in charge here?
Yeah, and the same thing happens pre-hospital because you hear cardiac arrest. I mean, here in New Jersey, we get an ALS unit, we get a BLS unit. Police show up, the fire department shows up, and some other places, they may just send a couple extra ambulances that they have lying around to help out. So now all of a sudden you have 10 people in there, and no one knows who's doing what.
Right.
And I think I think that's something that's cool about the way that this system is set up, that they have that in place, that they know that someone's going to be the team leader and everything. And I mean, it really makes a huge difference in the patient care and the flow of everything.
The system, the San Antonio system, based in the methodology, like I said, they had the 4-person fire company, and then it goes on to say that half of the fire companies have at least one paramedic trained firefighter. So that just adds another ALS level of service. So you have the 2 dual paramedic staffed ambulances, so you have 4 paramedics plus typically an extra, so you now have 5 paramedics on scene. So, and then you have 8 people, so if you have 5 paramedics on scene, that's more than most systems have going to a scene. I think it's great to be able to have that level of service available, but the feasibility of that,
right, isn't the hardest thing when you've been a team leader for a while is to stand back and let somebody else be the team leader? Right. To me, that's the hardest thing, when somebody else is working a code and you're standing there to just say, don't say anything, don't do anything, don't say anything, let them take care of it, because instinctually you don't want to do that, you just want to jump in. I know, if a patient is being intubated and is getting bradycardic, it's probably time for me to step in, right? But other than that, it's always a struggle to not step in, right, when people aren't doing well.
I think it's hard in everything we practice in now, and then just in any regular case. We're so used to going and getting our stuff and doing stuff, where sometimes we just need to wait, and sometimes a little bit of time, or sometimes a lot of time, or whatever it is, it really will change.
Don't just do something, stand there.
Exactly, and sometimes that's the best thing that we could do for the people.
Right. All right, what's next? Who's next? An article. Chris, you had an article?
Antibiotic one.
Yeah, you want to do
I think that'll be a good discussion.
Didn't we just discuss this a couple weeks ago?
Yeah, we were just talking about this.
And then I found this paper.
Yeah.
And who did this? So, Oskam, Oskam, out of the Netherlands. They always do the best studies.
Mm-hmm. And I think Scott Weingart and Rory Spiegel just talked about this on MCRIT as well. So this is hot topic.
Yeah, Rory has an EM nerd post about this.
Yeah,
as
yeah.
Well. So kind of interesting. Sepsis is obviously a hot topic lately, and this looks at bringing antibiotics into the field for prompt delivery of definitive care, because you always hear that antibiotics for every hour delay there's an increase in mortality. The Kumar paper that was a few years back, which I think there's issues with in and of itself, but nonetheless they're trying to bring antibiotics into the pre-hospital field to get early treatment going. So this is a randomized controlled trial. Just to kind of go down the PICO thing real quick, the population that they looked at here is greater than or equal to 18 years old, diagnosed or suspected infection, you had to have a temperature greater than 38 Celsius or less than 36 Celsius. You had to have a temperature to be enrolled. You have to have at least one other SIRS criteria, which at least in pre-hospital you're not going to have a white count, so that only leaves you with so many other variables.
Which we really don't use anymore either. So.
Which is again proven that it doesn't actually.
But we only
very much-
recently stopped using that for the most part.
And they use the 2001 definition of sepsis, so they're using sepsis, severe sepsis, and septic shock. The intervention here is administration of 2 grams of Rocephin pre-hospitally. And
So what we're saying, just for the audience, is now we used to use SIRS scores for decades, and now we're using like SOFA and QSOFA.
Which they use. They also do disclose here the SOFA scores as well for these patients. So the intervention group here is 2 grams of Rocephin administered IV, and the control is just usual care, so some IV fluids basically as indicated. And so their primary outcomes that they look at is the primary outcome is all-cause mortality at 28 days. They had a bunch of secondary outcomes that they looked at, number of misdiagnoses, mortality at 90 days and during the hospitalization, the length of the hospital stay, ICU admission, ICU length of stay. Then they looked at time to administration of antibiotics in the ED for the usual care group, who's coming in with no antibiotics delivered, and time to antibiotics in the pre-hospital group, the intervention group. They looked at adverse events as well, and overall quality of life. So they enrolled almost 2,700 patients over the course of about 2 years. And essentially what they found is that there's really no significant difference in any of the metrics that they looked at for the most part. This was also part of like a QI project for them as well, so they kind of re-educated both pre-hospital providers in sepsis recognition and early intervention, and they also re-educated their ED staff from the docs and the nurses and everything about prompt recognition and administration of treatment. And so I think what you're seeing here as well in terms of their numbers is that this is favorable numbers for them because they just had an in-service on it and they were just taught that they should be aggressive and treat early on. And so basically what they find is the intervention group received antibiotics at about 26 minutes before arriving to the emergency department. In the usual care group, meaning the patients that didn't get anything pre-hospitally, it was 70 minutes. So there was definitely a delay when you look at the pre-hospital administration versus the usual care group. But ultimately that didn't really amount to anything statistically significant.
What antibiotics did they give?
So they gave Rocephin, and then they document that, if you have an obvious allergy, or anything, you'd be excluded
Right.
As well. So,
which is all kind of silly because Rocephin, we all know, is a very easy drug to give. It's almost
Right.
impossible to mess up. You can bolus Rocephin. They were giving 2 grams, you said?
2 grams.
So
2
they were
grams,
giving meningococc, or they were giving meningitis doses, right? And it's great for urine. It's okay for lung. It's good for Lyme. It's good for gonorrhea and like 20 other things. So it's hard to mess it up. And it probably was the right drug to pick, right?
So a couple of things with this. So they look at, and they say at day 28, 8% of the patients had died in the intervention group, and about the same had died in the usual care group for no significant difference. And then you look at, they said 7% of patients in the intervention group, and then 10% in the usual care group were readmitted to the hospital within 28 days, and that was statistically significant for them. So that was really the only difference that they found within these 2 groups, which I don't really have an explanation for, but just to kind of pick apart some of the details that are in here, if you start to look at the patient population that they specifically examined, again, this isn't United States, so there's probably some variance, but a lot of these patients were already on antibiotics, PO, originally, and then you look, in each group, almost 3/4 of the patients are referred by their general practitioner, so they have another doctor that's referring them in, which at least in my experience isn't necessarily who we're getting that's septic. It looks self-referral is only 1/4 of the patients. A lot of times you'll see the septic nursing home patient that comes in and they've already gotten antibiotics and they have chronic infections and whatever else. That's one subset of the patient. They also usually come in sicker. And then you look at the priority calls, like the priority stratification that they do in terms of life-threatening, urgent, non-urgent, and you look at the QSOFA scores here that they have and the severity of sepsis, and it's just not a sick cohort. So I think that 3% of the patients in the usual care group were in septic shock, and 4% in the intervention group were in septic shock, and I think that's where you see the difference, if there was a difference in this treatment. And I don't think that 3% of the roughly 1,000 in each group is not enough sample size to see if there's really a difference. There may be some benefit in giving Rocephin to people who are in fluid septic shock that are hypotensive and requiring pressors, but for everybody else who's kind of non-severe sepsis, it says if some of them were just discharged home, I don't, in the population that they're examining, I wouldn't expect to see a difference overall in early antibiotic administration. And I think you look at some of the other metrics, in terms of the fluid resuscitation that they're giving in the ED, and again, these patients just aren't that sick. They're getting a liter of fluid. Some of them are getting discharged home, and only about 3% of them are actually in septic shock. And so, I think that the question remains is what cohort would this be beneficial in? And I think that it's severe sepsis, septic shock, people who are sick, where this makes a difference.
So that sounds pretty good. So you think the study didn't answer their question because we looked at the wrong patients?
Right.
So based upon the study, I get the feeling like you can't make a recommendation for this one way or the other.
No, I think somebody who's who's hypotensive, who's febrile, who's tachycardic, that fits the picture for septic shock is somebody who's going to derive benefit. I mean,
but that's just subjective opinion. That's
right.
not based upon this article.
No. But even you look at, the New England Journal paper that came out too, that looked at the New York data that's pooled, and even in their data, the odds ratio is not impressive for time to treatment in early antibiotics. It's
Right.
1.0 something. It's nothing that's overly impressive.
Right. However, you take a patient in septic shock, you put him pre-hospital, you put him in Middle America, where it might take 2 hours to get antibiotics when you're in septic shock. Maybe those odds ratios change now.
Right.
But maybe they don't change for us. So what did Dr. Spiegel say?
So I think he says similar that it's not a sick cohort. It's number one, you're assuming that antibiotic has a role in, or early antibiosis has a role which is debatable based on the prior evidence and prior studies that are out there, and that if you're looking at this data, it doesn't really, the population that you're looking at doesn't answer the question that you're asking essentially.
So if you had to make up a protocol, you would just make it up based on what you're saying without good data.
Right. I don't think this answers anything. It says that there doesn't appear to be much harm in giving antibiotics early, but it doesn't appear to be any meaningful benefit
Right.
in terms of patient outcome.
I mean, we know the risk of harm is always that you mix it up with another drug, you're giving for another condition, which is reality, albeit that Rocephin is a very safe drug, right? And even the allergic reaction stuff with Rocephin is incredibly minimal.
For me, this article drove home a major point that I learned somewhere. It was either second year of residency or even kindergarten. It could have been then, but it was I had a wise PICU attending who taught me that fever does not mean ceftriaxone deficiency. So use your brain and look at the patient, and evaluate whether or not they really need antibiotics.
So that's brilliant because fever means, until proven otherwise, viral.
Right. How many of this cohort do you think had the flu, or how many of them do you think had a really bad bronchitis?
And many
or
people
something
get
like that? It's like,
discharged home.
right, exactly. So, and
I'm coughing really bad. My head hurts really bad. I think I need some antibiotics.
Yeah.
And I always say I'm going to give you antibiotics for your virus, and nobody laughs.
Mhm.
And but it's
we all get the text from family members saying, "Hey, I've got a sore throat, stuffy nose, headache, and I can't stop coughing. Please call me in a prescription for antibiotics." And I mean, I'm not nice, I guess, because I say I could give them to you, but they're just going to hurt you. They're not going to do anything for you. Nobody believes me. They think I'm just being a jerk. So
Right.
I'm just going to give you diarrhea. It's just going to give you diarrhea and make you more uncomfortable. So, like,
Until you save the day with TXA.
right.
But what you're saying is, in many studies, the number needed to harm is less than the number needed to treat.
I would say probably. I mean, yeah.
Or the number needed to harm is greater
It's
than the
greater
number
than the number
needed
you treat, right? So,
Right, for the average person, for all comers, when they get it for what's typically viral syndromes.
yeah.
what's the best antibiotic for bronchitis? And the answer is 1, bronchitis is viral, and 2, we have no good definition of acute bronchitis in medicine.
I think that's also, it shows, we get so hung up on these metrics and everything, with our sepsis bundles and getting antibiotics within the first hour of arrival to the hospital and getting, the lactate levels and the fluid boluses. And this goes to show even before the hospital that, when these people who meet what we would define as sepsis criteria based on when they come in the ER, that they're getting these antibiotics and it makes zero difference in their care. I mean,
Right.
These are the people that are getting antibiotics when they come to the hospital as well, possibly.
And I agree with Chris, IV fluids, 30 per kilo makes a difference if you're hypotensive. But
Right.
if you're not hypotensive and you have a fever and you're coming in this winter and you probably have the freaking flu, 30 per kilos has been shown to harm, right? Early antibiotics don't work because this flu is viral, right? And, and that rare person with a secondary bacterial infection, which is what we all hope for, so we have a reason to give antibiotics, is just sort of absurd. And then we overcall and infiltrate on chest x-ray, right? Which we all do.
It's probably an evolving pulmonary edema because they got 30 cc's per kg pre-hospitally.
Right.
That's
of
the
course.
infiltrate we're seeing in treating.
Right.
then
And by the way,
another disease when they got
even
there.
the protocols don't say you have to get 30 per kilo as a bolus, right? They give you hours to give it, right?
Right.
Even if it is indicated, based upon no good data. All right, what's the next study?
We can go back to TXA.
I'm surprised none of you want to do siren exposure to doctors. So TXA pre-hospital 100.
Where is this article?
Philip Stein.
So not the pig
Oh
one,
yeah,
right?
the impact on
Yeah,
pre-hospital
not the pig one.
PXA on blood coagulation in trauma patients. Yeah.
Out of Switzerland.
Yes, I thought this was actually a cool study. This study was a prospective multi-center observational study. Basically looked at giving TXA on scene versus, there was the TXA group that was on scene versus a control group of previously published people without TXA. And basically we're looking at different coagulation tests and blood gas analyses on scene and emergency department to determine if there was what happened with the values of different coagulation assays. So this was kind of interesting to see. What they did was they drew blood right before giving TXA in the hospital, a couple different vials, and they drew blood as well when they got to the hospital. And they looked at the coagulation values of ROTEM, which is, they looked at ROTEM, INTEM, XTEM, FITTEM, APTEM. So these are all different values, basically, of coagulation assays to see how well the polymers are holding on to each other within the fibrinolytic system. So there were, I guess, 70 people who were in the TXA group, and then there were 38 people in the control group that they looked at. Now, when they looked at these, the reason why there was a variability in the amount of people was because they wanted to try and match the people as best as possible to account for potential differences in epidemiology, vitals, severity of trauma, and body region exposure of where the trauma was, if people got crystalloid or colloid resuscitation fluids. So after all that, they basically had 24 per group. And what they found was that, well, there are a couple of different things that they found, but for the so the first is a change of ROTEM maximal clot firmness from on-scene to ED. So in the FibTem maximum clot firmness, so that representing the functional fibrinogen polymerization, it basically did not change from on-scene to ED in the TXA group, whereas there was, in the people that did not get TXA, there was it did change. So meaning that the decrease from the on-scene to ED was significantly so compared to the control group, basically the maximum clot firmness was preserved from the time they got the TXA in the field until the time they got to the emergency room. Whereas in the control group, this firmness wasn't preserved. So this would show that there would be potentially an increase in bleeding had this person not get TXA versus having gotten the TXA pre-hospitally. And then when they looked at fibrinolysis, so this was with the XTEM, on-scene hyperfibrinolysis was present in 4 patients in the TXA group and 2 patients in the control group, but the hyperfibrinolysis was blunted in 4 patients in the TXA group. So with the XTEM as well, they found that patients had a reduction in the hyperfibrinolysis, meaning the clot was able to maintain better in the patients that received TXA. The changes in hematology and blood gas analysis from on-scene to ED, they were not significantly differences between the 2 groups, but when they looked at changes of coagulation assays from on-scene to ED, so on-scene, the fibrinogen fragments represented by D-dimer levels, so they would check a D-dimer level, and as we have more fibrinolysis, the D-dimer level goes up. So D-dimer will go up generally as injury severity goes up. However, in the people that got TXA pre-hospitally versus the people that did not, they found that there was a higher level of fibrinogen fragments in those that did not receive TSA. So there was more fibrinolysis basically in the patients that did not get TXA pre-hospitally. Again, showing that there was probably decrease in bleeding, and this clot was able to be maintained better in the patients that got TXA. So this is just another study out there, and this is shows a little bit more of kind of the science behind the way that the fibrinogen system works, and this is a way to kind of look at this even a little bit more scientifically, I think. So it's basically just showing that these clots are staying better, they're staying more firm when people get TXA. They were recommending that, and I think it's again, just shows that basically TXA is a good drug to give pre-hospitally, and the earlier on they get it, the better off that people do.
And this was in an anesthesia journal, right?
We talked about this in the GEMS article too. I mean, I think this was a good study. It showed us some good outcomes. They weren't patient oriented, but you do see, like you said, the science side of things. I think there's that big Cochrane review in I can't even remember when now. There's so many studies now, but they basically discredited the thromboelastogram as a reliable indicator of the efficacy of TXA. Basically because it's not used routinely, it's not readily available at all hospitals, it's still not the standard measurement of this. I'm glad that they did D-dimer because that gives a more relatable number and something that people can relate to, because TEG is not available at most hospitals or pre-hospitally. But when you say D-dimer, everybody knows what you're talking about, right? So I'm glad that they talked about that a lot, and it was significantly reduced as well in the TXA group. So, but yeah.
All right, that sounds good. Does one more person want to do the last one, the noise exposure? I get emails about this all the time. Can you send me articles about noise exposure?
Let me see.
We don't have to do it. So
We can talk about it
what's
if,
the rule? Is there do we have any rule about how often we have to do hearing testing? Do you guys think subjectively your hearing is getting worse because of all the sirens you've been exposed to?
I don't know if it's the
I think
sirens or
so.
my old age.
I mean, to summarize this article real quickly, they were just basically looking at paramedics in different environments. There was the MECU, and then there was HEMS that they looked at, and they measured the decibels of various settings by using these contraptions that had earmuffs on the helmets, right? And they did. I think ultimately the take home was they did find a significant increase in decibels in HEMS personnel exposure and everything like that, but the outcomes that they measured, ultimately they didn't see a hearing loss reduction that was significant. So, but they only looked for, I don't know what their follow-up period was, I can't remember.
I was still a little surprised about that.
Yeah. So
I think sirens have affected my hearing.
Yeah, absolutely.
Right.
And I think it's more of a long-term effect. I mean, because look at my parents who, maybe they went to Woodstock a little bit too much. Now they can't hear anything that I'm saying. No, I'm just kidding, Mom and Dad, I love you. But, I think it's
Are they
more-
watching?
Probably. I think my mom was at some point. But I think it's going to be a drawn out effect over a substantial period of time where, paramedics in their 20s and 30s are being exposed to, everybody's laughing, being exposed to these loud noises. It's going to be worse when they get older. The what deers and the I can't hear a thing you're saying is going to be significantly increased. We're going
Right.
to be able to measure that.
And so the next question is, what about these European sirens now? Like Mount Sinai in the city is using European variants.
The one that kind of sounds like an angry donkey, right?
Right. Well, it sounds like what you hear, like in London or in Europe.
Yeah, I don't think those are
as opposed to our whales and high-lows and.
They have these rumblers that New York City uses. I mean, that's a really
Oh,
good,
yeah.
I mean, very low frequency, but they
Yeah.
make the ground shake you. And I mean, like,
Is that to help people who live near the hospital? Because everybody lives near a hospital in New York City, and so it doesn't sound as rough.
I mean, I think it's very effective.
When you
To be
get
honest
when
with you.
one of those pulls up behind you and they do it, your whole car shakes.
Well,
So
one of the
even if your
problems-
music is blaring, you're just like.
Sirens are far less effective because of the soundproofing in cars these days.
Yeah,
We
and
actually
people
did
have their
a-
headphones in when they're
a
driving.
video on it a few years ago. It's virtually impossible to hear an ambulance until it's right on top of you in any of these new
Right.
cars with just really advanced soundproofing.
Plus the European
those may be
sirens
a
are.
response to creating vibrations to get people's attention more than anything.
Okay, that makes sense. Plus the European sirens sound differently, so maybe you just pay more attention to it because we all don't pay that much attention to sirens if we hear them a lot.
Yeah, could be.
But I mean, many of you guys were paramedics. Don't you think that the sirens affected your hearing? I mean,
Absolutely.
yeah.
Yeah,
Over the
and-
years, I did.
I think it does, and I mean to repeat what you're saying is a lot of people aren't listening to the sirens anyway. I don't know, maybe it's a New Jersey thing to have your headphones in while you're driving. Maybe some people can comment who are listening from other states, but people don't listen to they can't hear anything around you. So you
That's
could
one of
be
the reasons they moved the sirens down to the grills, because the sirens always used to be on the roofs of ambulances and like that. And it was literally right above your head, and they moved it down. That was, one of the safety features to try to preserve your hearing.
Some of the trucks at the units I used to work with, everyone had headphones and radios in the truck for that very reason.
Right, but I wonder if that is real or just seems right.
Certainly expensive.
Right, I'm sure, sure. All right, anybody else want to do anything else? I'll send out articles, no? All right, I'll send out articles for 2 weeks, the next couple of days. Lots of good stuff in the literature, like exciting articles. Thanks again to Staten Island University Hospital. We will be back in 2 weeks. Everything is on the website, addresses, locations. We've updated stuff. We're creating links to the website for the Journal Club articles. If there's an old article that you want, let us know, because many of these articles are copyrighted, so we're only going to provide the links for brief periods of time, so only to be used for academic purposes. If you have any questions or comments, please let us know. Join our email list, and we will see many people in San Diego at AMSP conference. Thanks for tuning in.